It gives me great pleasure to introduce our two panelists today. We have Dr. Eric-Feigl Ding, who is a leading epidemiologist. He is a health economist and senior fellow at the Federation of American Scientists. He was with the Harvard School of Public Health for more than a decade, for more than 15 years. Sujatha Rao has been the former health secretary of the government of India, and at the center, she has been at the forefront of formulating policy and therefore someone important to talk to as far as our vaccine roadmap is concerned and what we can expect. So thank you very much to both of you for joining us. Dr. Feigl Ding, let me begin by asking you about the Delta variant, which was the variant that originated in India. You have described that today in your tweet as a triple threat. Can you explain to us why that is and what that means?
Yeah, thank you so much for having me. Happy to be here. I think Delta variant is very worrisome, as we've clearly have seen the outcome in India. But right now in the UK, it's also seeing a surge. In the US, it's also seeing a surge. And it's surging for many reasons. One, it's more contagious than almost any other strain variant. It's 50% more contagious than the B.1.1.7 alpha variant from the UK. And that variant was already 50% more contagious. So we're talking about almost 2x more contagious than the original Wuhan strain. And the latest data shows that it's about 2.5x greater risk of hospitalization than the alpha variant, which again was already 60% greater risk of hospitalization than the original. So now we're talking about almost over 4x greater risk of hospitalization than the original strain. And then there's also the issue of decreased vaccine neutralization and efficacy. We don't know the precise number. There's several studies out there, but we know that at minimum, the first dose with this Delta variant, the vaccines are much less efficacious. And one dose is just not enough. And many scientists, and even Dr. Fauci, also agree one dose is not enough for the Delta variant. So I think these three factors combined, contagiousness, severity, and vaccine escape, well, just reduced efficacy, is a cause of concern because much of the world is not heavily vaccinated. But UK is already over 70% one dose, 42% two dose, and it's still seeing a surge and still seeing hospitalizations rise. So if it's happening in the UK, despite all those heavy vaccinations, we know that the rest of the world is in danger.
Can I ask you a follow-up to that, which is that, would it be fair to say that it's not just the number of infections that should worry us, but it is greater hospitalizations that should worry us? Because we do know that the vaccines cannot stop us from getting COVID. What they are supposed to do ideally is to reduce the severity of disease and hopefully prevent us, from being hospitalized. So as a scientist, as a doctor, is that what you would like to see? I mean, will we come to a point where if enough people are vaccinated, you're not going to be so worried about the number of infections as you would be sort of looking at the hospital data? Is that what your focus would be?
I think there's two ways to look at hospital data. Yes, the vaccines, two doses definitely reduce hospitalization and deaths a lot, significantly. But the issue is on hospitalization, it's more of an individual level risk. Like herd immunity, all those things, they don't really apply to hospitalization. So hospitalization, yes, if we can get everyone vaccinated, that is obviously the goal. But if half the world, or 3/4 of the world is not vaccinated, the hospitalization issue, it doesn't solve it for the rest of the world that hasn't gotten it. Now, the infection, it does reduce infection a lot. It does, about 60% efficacy with the AstraZeneca for two dose and 85% or more with Pfizer. But I think that the infection in certain ways, it slows down the transmission, but it doesn't eliminate it. And by not eliminating it, it's about 30% with one dose, according to one recent UK study. By not eliminating it means that vaccinated people can still carry it to others. And we've actually looked at, adjusted for a vaccination, the risk in unvaccinated people, even in the US, where cases have dropped 90%, or hospitalization dropped 90%, the risk in unvaccinated people has been pretty much steady since late January and February because the infections are happening among them, and our vaccination rates are not enough to prevent them being infected and hospitalized because we have a large swath of people not vaccinated.
Sujatha Rao, given what Dr. Feigl Ding just explained about the efficacy of vaccines, and that therefore we now do know data shows that one dose is not enough to deal with the Delta variant in particular, we need to have both doses. Do you think the government of India needs to reverse this interval that it's kept between two doses of the AstraZeneca/Covishield vaccine? Because we increased that to 12 weeks. The UK did the complete opposite because they were worried about the Delta variant and reduced the gap to 8 weeks. So is it time for India to do the same?
I think so. I think, these kind of changes in dosages and gaps when you should do is a constant when a new vaccine is being introduced. We saw that happen in polio also. It took a while for the final stable dosage and vaccination schedules to emerge. So I really think government should not be worried about being criticized that, giving the perception that they once again change. After all, this 3 months to 4 weeks, 4 months was a recent change. And now once again, they come back to 2 months. I think what's worrying them is the public perception, feeling that the government doesn't know what it's doing and they're flip-flopping all the time. But I think every day new evidence will be coming up. And with new evidence, you have to change your strategies. It's very clear from whatever we've seen, including a recent AIM study has shown that even despite taking two shots, still they found 7% getting the infection. So, these are very powerful findings. And I do think that they should immediately reduce it to 2 months because we cannot afford a vaccine that is suboptimal after one dose, because then they're as vulnerable to infection as others who are not vaccinated.
There's an interesting question that has just come in, and I'll take that to you, Sujatha Rao, from Balkumar Marthi, who's asking that, many countries have introduced penalties for people who violate quarantine protocols and social distancing rules. But when it comes to vaccination, it's being left to individuals and their preferences. So why should we tippy-toe around individual rights when it comes to vaccinations? It's a controversial issue. Should vaccinations be compulsory? Should we fine people who are not vaccinated? There is a sort of fundamental right that is also at play here. How do you see that?
I don't at all believe that force should be used in public health. You have to bring about behavior change. And if you force people, they're going to resist even more. And particularly in this case of the vaccines, which are still work in progress, it's not with any certainty that we are even able to say for how long the immunity will last after you take these vaccines. So, I don't subscribe to using force. I think if people have vaccine hesitancy, it's our job to really convince them and bring them round and be there if they get an adverse consequence of vaccination. The system should be able to reach out and take care of them. That is the biggest fear. And as long as that confidence we are able to give, people will turn around. And I really think this has got nothing to do with individual rights. I think it has everything to do with persuading people towards a proper behavior change for societal good.
Okay, we have Tarun Goyal who would like to ask a question. Tarun, are you there? Please unmute your mic.
Yes, ma'am. My question is, in India, rate of vaccination is very slow. It may take another few years before all the population gets vaccinated. Meantime, we'll require a booster dose as well. And there are mutants and variants all the time. Does it mean countries like India will have to be struggle for a long time to be over from this pandemic? And when do you see any possibility that Indians may go out in public without any mask as Americans are doing today?
Okay, I would like to take this question actually to both the panelists, and Dr. Feigl Ding, to you first, because there is some controversy over the CDC also recommending that people who are double vaccinated can, interact without masks. And I've seen that you've been critical of that. I don't think you think that that's necessarily the right thing to do, but are we ever going to come back to that point where we will be without masks?
Yeah, I think this is a very, very critical question and with lots of nuances. I think in America, the issue is there's a lot of people who are vaccine resistant. And so when you see someone without a mask, you don't know if they are vaccinated fully or they are just anti-mask. And so if you have a vulnerable family member at home, or you have a child who's not vaccinated, or someone who's immunocompromised or has cancer, you don't really know, should I take a risk of interacting with this person at the store? Or should I wear a mask just to be safe because I don't know if they're vaccinated or an unvaccinated anti-mask person. And so I think that is really key. Everyone has their own family risk, profile gradient that you have to take into consideration of. I think the other issue is, transmission. There is asymptomatic transmission. We know that. Asymptomatic transmission is not part of most of the vaccine efficacy numbers. Just so you know, the AstraZeneca vaccine, Covishield, in a Lancet report for the Alpha variant, while it's 77% for the symptomatic, it was only 29% efficacy against asymptomatic. And asymptomatic transmission, we know last year was about 30 to 50% of all transmission. So that's inherently the reason why we know for the actual transmission, not just symptoms and hospitalization, but the actual transmission carrying it silently, which is a large part of transmission, vaccines are not foolproof, and that's why you need masks. And as for the gentleman's question earlier, India obviously is taking a long time to vaccinate. I'm hopeful the COVAX in the US will be able to donate many more vaccines. But at the same time, I think outdoors, for the most part, is low risk unless it's very, very tightly congregated, such as sporting events, concerts, or religious gatherings of high density. But I think outdoors is relatively okay. It's the indoors that I worry about. And unless you ventilate a building well, open windows or disinfect the air indoors, that is where the greatest risk is. And that's why you might have to mask indoors.
Okay, so I guess we're not potentially looking at being maskless for some time. But Sujatha Rao, given the question that Mr. Goel asked, do you think therefore the sort of publicly declared target by the government of India to vaccinate all adults by December of this year is a realistic target? Is it going to happen?
I don't think it's a realistic target. It's an aspiration, which if they put it so high, maybe they will reach halfway. One can't really say to what extent we will be able to achieve. It's a very tough call, largely because we still haven't got a grip on the supply side. In my mind, having gone through two big public health programs in my career, I'm quite confident that we have the capacity to vaccinate 1 crore, 10 million people a day. That institutional capability is there in the country, but of course, joining up both public and private energies. But the problem here is not that, it is the supply. And that's where I think government has goofed up. We have delayed placing orders and focusing on this whole vaccine supply issue. And today we are facing a shortage. It's really the result of what we did not do in the past. And you can't force a quick supply. It's not some chocolates that you're buying off a shelf. But what I'm confident about very clearly is that the several companies, almost 7 companies are working on vaccines in India. They will all come to a fruition by November, December. They'll get into production. And by the first quarter of next year, I'm quite confident that we'll not only be in surplus vaccines position, but also that prices will drop hugely. Yeah, so, it will be more accessible, more easy and easily available. But I'm afraid for the next 3 months, it's going to be a painful start. And that worries me because if wave 3 does hit us, we will have to go through that pain because we would not have secured ourselves the firewalls to fight wave 3 with vaccination. So I'm afraid we have to be prepared for that scenario. But I'm not at all sure that we can achieve the target. For example, and I'll close with that, In June, both Serum and Bharat Biotech supplied us about 6.6 crores, 60 million vaccines against what they had promised of 9 million. Now in June, they're promising 100 million vaccines, which I don't think they'll be able to provide at all. So, it's the supply side. The last point is that, much of the supply is also stuck because of the Defense Federal Act in US. They're not getting the raw materials. And unless and until US really opens its, palm and allows takes off the export restrictions and allows these raw materials to reach us, our supply will be constantly hindered.
Abdul Razak has a question. In fact, he is with us at the university and is on the COVID help desk as well. Abdul Razak, are you there? Please go ahead with your question.
Yeah, good afternoon, everybody. This is Abdul here. And my question is to Dr. Feigl Ding. Just wanted to check on what is your take on the indiscriminate or incomplete vaccination. There are reports in the media telling that this could trigger emergence of mutant strains. And there is no need of inoculating the people who have already documented with corona infection. So what would be your take on this?
Well, I think people with previous infection, they are protected partially. They're not fully protected because we know that if you give someone with prior infection, prior antibodies, another vaccine dose, their antibody levels and titers actually increase a lot, substantially. And and also we know from previous studies in Denmark of millions of people that reinfection definitely happens. And even before the advent of variants, reinfection definitely happened pretty often. That basically previous infection only protected you about 80% efficacy, I guess, if you put it in quotes. But that again is the old strain, not the new variant. So 80% is good, but it's not full. And that's just, again, for symptomatic, not asymptomatic. I also someone did propose that one way you could save vaccine doses, and this is not official guideline, it's some discussed among some immunologists, vaccinologists, is if you previously have an infection, one vaccine dose you definitely need, but the second vaccine dose you may not need, because one prior infection plus one dose puts you about the similar neutralization and vaccine antibody levels as two doses for someone who's never been infected. So that could be one way to save doses. But the thing is, you need antibody testing to confirm that, and that in itself will cost more money and time. So I think generally 2 doses is still the better way to go. But I just want to emphasize that one prior infection does not guarantee you prevent your reinfection. If anything, the latest studies in the UK on the Delta variant versus the Alpha variant, which we have the most data of, it shows that Delta variant seems to have 4 times greater rate of reinfection than the Alpha variant. And now we don't know the exact rate, it's just relative, 4 times greater, according to the UK data, and still early, but that suggests that with the Delta variant, you definitely should not rely on prior immunity to an older infection you had last year.
So if I could follow up and ask you that if somebody has recovered from COVID, what would you say is the ideal gap between having had the infection and getting your first dose of the vaccine?
We don't have exact studies on this. What is the best? If you previously had it, you should still get a vaccine dose. At minimum, you still get at least 1 dose. But I think that delaying the second dose for someone with prior infection seems relatively okay, because they already had a 1+1.
But is it like 4 weeks after your infection, or is it?
We don't have studies on that. We really don't have studies on that, because we don't. To have studies on that, you need very precise timing, and a lot of the previous infections were not timed with vaccines. The general rule is some places say you should wait 6 weeks. The CDC once said you should wait 90 days if you previously had infection before getting vaccination. So those are just numbers and guidelines, but they're not like locked down in hard evidence.
Sujatha Rao, before I go to Kaushik, who's going to ask one of the next questions, one of the big problems India is facing is the issue of vaccine inequity. And that's happening for various reasons. There is vaccine hesitancy, there is a digital divide, there is an urban-rural divide. I was reading today that a lot of the vaccines that India has have been sort of taken up by corporate India to vaccinate their employees and their employees' families. So that immediately, brings in more inequity in the system. As a policy maker, what would your advice be to deal with these sort of multiple inequity issues that we're facing currently?
The two things where I find some amount of problems with even the revised vaccine policy, and that is that I'm not against the private sector, but I do feel the government should have said universal access to free vaccine, and the procurement of the vaccine is the sole prerogative and responsibility of the central government. So you have a single procurer. And they in turn leave it to the states. The states then sit down and make their micro plans of to say who all have to be vaccinated and where do they, after all, it can't all be done by the government facilities alone. They have to co-opt the private sector. The private sector does deal with a certain clientele. And so they will be able to make a plan and then distribute the vaccines between the public and the private sector in an equitable fashion. So that would have lent much more of equity between rural, urban, poor, rich, and so on and so forth. Having said that, there are two considerations that the state government would keep in mind while they prioritize and phase out the populations to be vaccinated. One is they will be most anxious to get the economy back, the education system back, the workforce back into work. There's no doubt about it. So people who really interact a lot and more vulnerable to infection, such as taxi drivers and school teachers and factory workers, migrant labor, they would probably be the ones they would like to prioritize and vaccinate first so that they can kick in these other externalities that will be falling from this vaccination drive. The second is, which is a much more scientific way of going about the whole vaccination drive, is to look at epidemiological data. And what the government of India had done first to prioritize all those above 45 comorbidities and the elderly was based on such epidemiological data. And I do believe that today we have only vaccinated 50% of them. That should be the first charge on our vaccination drive, that we ensure that this inequity doesn't come where at random any 18-year-old is vaccinated when he's not so vulnerable or so such a priority factor as against a 70-year-old with huge amount of comorbidities who come a wave 3 would probably lose his life. So, there are these health inequities, the epidemiological inequities, the rural-urban inequities, and even in areas where the infection is most rampant, the hotspots would come out when you do serosurveillance studies, and that data also has to feed in. So a vaccine strategy is never just done on ad hoc political calculation on an arbitrary basis. A lot of data analysis is done from drawing in data from multiple sources and then put together to understand the story. And then you chase and develop the firewalls, as I would say, and ensure you protect and insulate the people from further infection through the vaccination drive. So there's a lot of strategy and strategizing that goes into vaccination, and not blindly hit wherever you want. It's not numbers that matter, but who comes first is very, very critical.
Yeah, absolutely. And unfortunately, everything has got politicized at the moment. Yes. And I think the fact that we don't have data that is being made publicly available, at least.
Yes, so analysis is not
exactly there. That's not there. And that is a major weakness. Kaushik, please go ahead with your question. Kaushik, if you're there. You'll have to unmute your mic, Kaushik. Are you there? Okay. I don't think Kaushik has logged on, but I have his question, and this is for Dr. Eric Feigl Ding. He's asking about long COVID and how much of a problem it is, and your take on that.
Yeah, long COVID is a very worrisome issue, and the rates depend if you've been hospitalized or you haven't been hospitalized. But overall in the UK, about anywhere from 1 in 7 to 1 in 12 people have long COVID beyond 12 weeks. And this is a very worrisome number, because if you take the number of people infected and multiply that by just 1 in 10 approximately, that's a very, very large number of people suffering long COVID. And we're talking about not just like long-term inflammation or organ damage, but also cognitive dysfunction, brain fog, fatigue. And there was just a story in the US of a 14-year-old gymnast who used to train 4 hours a day. She's a very high-class gymnast, and now she can't even get up. She can barely walk. She gets dizzy. She can barely concentrate. And again, she was only 14 years old and was a national level gymnast. And these kind of, even if athletes are even being cut down by long COVID, I think people with comorbidities would definitely see even higher risk. And the two groups in UK with the most long COVID, healthcare workers and teachers. And that's the worrisome thing, because they're obviously the most frontline facing COVID patients, as well as children who definitely do infect, no matter how some people try to deny it, because the latest data clearly show the rise in cases in the UK, in India, in Singapore, in the highest number of incidents now recently is in children. And so I think we have to be really, really careful about long COVID. Long COVID is something that is not just for those who are hospitalized, but even those who have never been hospitalized. And there's actually some studies that shows there's several points in IQ drop for people with long COVID. And this is why the long-term cost of disease burden is not just deaths, is not just hospital costs, but the long-term care needed for all these COVID patients. And that will ultimately be the long-term legacy of COVID if we don't stop it sooner.
So my follow-up to that would be that, let's say someone has had COVID, whether they were symptomatic or not, they've recovered, and they would like to get back to working out. One, again, reads a lot of conflicting advice on this. Some doctors say wait for a couple of months. Some have suggested waiting for 6 months, just take a walk. Is there a one-size-fits-all advice for everyone? Or my doctor said that he, for example, has met patients who were otherwise fine, but developed heart issues post-COVID. So he's very cautious about returning back to a workout routine. So what would you suggest? What should the ideal gap be before one can get back to heavy exercise?
Yeah, there's no one size fit all, because in certain ways, the other mystery right now is doctors can't predict or can't really find the risk profile of who are those who suffer long COVID long term. Because, for example, hospitalization and ICU and death, we know are people with pre-existing conditions, comorbidities, cardiovascular disease, diabetes. But for long COVID, we haven't really figured out, other than, having a greater COVID severity puts you at higher risk. But even asymptomatic and mild cases have suffered long COVID. And that is really ultimately the mystery. And for example, this 14-year-old gymnast, the headline of the article is, she had long COVID and doctors can't figure out why it hit some people and not others. And that's the greatest mystery. Now, there are long COVID studies being undertaken by the NIH here in the US. There's several long COVID studies that are now starting up. But this is currently the biggest mystery, because it is the hardest to study right now, because it takes such a long time follow-up. But I just know that we should not take the risk. We, like our society, should not take the risk right now of going without mask, not having ventilation, and whenever we can afford it, not purifying the air and disinfecting it. And of course, foregoing vaccines. I know it sounds silly to the rest of the world, but in the US, vaccine hesitancy and conspiracy theories are incredibly frustrating. So I think all of them, we should not take the risk. We have to mitigate the risk as much as we can and really, really think of the children and our future generation.
Absolutely. And I mean, vaccine hesitancy there are very similar sort of issues, maybe in different contexts, but there are conspiracy theories, infertility being one of the silly ones that one has heard in many parts of this country, among other things. Sujatha Rao, there's an interesting question we've got from Wasim, and I'll take this to you, that Kerala's health minister, Shelja, former health minister, had said that we should have had a nationalized healthcare system. Do you think we would have dealt with this pandemic better if healthcare was a central subject and not left to individual states to deal with?
I don't think so. I think, if in the federated structure, because pandemics are something that are very, very, you need to have local participation. I fully believe that you can't control a pandemic by a jumbo hospital constructed in a park. The pandemic can only be controlled when you have the community fully engaged. And Nidhi, you saw what happened in the polio drive. It was an all society, all country effort. Everyone from top to bottom were involved in the polio eradication, the polio pulse days that we organized. So unless and until the communities are involved, the health workers are involved, the community leaders are involved, civil society is involved, every range of society is involved, and this is something, it's an infection that's not hitting only children, it's affecting every strata of society. It has to be an all-society approach. And these approaches are very dependent on local dynamics, local cultures, local beliefs, and therefore it has to be a very decentralized approach in handling it. Where we've gone wrong in India is centralizing the entire policymaking and effort into the hands of few people in Delhi. And that's why we've been failing at every step. It should be a decentralized approach within very broad, scientifically evidence-based, as evidence-based guidelines that must give the technical justification for what we should do and what we cannot do. And that must come from central government. So there is a certain amount of standardization of approach, as we've seen in all our, in the handling of all our infectious disease pandemics like HIV/AIDS, or whether it is polio, whether it is other programs like TB and so on, which we are struggling even now, but with a decentralized strategic plan to be developed in consultation with the communities. So I don't think a national health policy, national health program decided by a few bureaucrats in Nirman Bhavan would have been able to do much in this pandemic. Kerala itself is such a beautiful example. Yeah. What Kerala has done, no one else has done. Do you think Bihar, government of India would have been able to think of what Kerala has done and get Bihar to do? No, the context is different. Capacities and capabilities are different. So different strategies have to come out.
Okay, Dr. Feigl Ding, when we talk about inequity in vaccination, that's true also at the global level, isn't it? Because you have now the sort of developed world surging ahead with their vaccination drives. There's a lot of criticism of the US at the moment. I mean, you have some millions of doses of AstraZeneca vaccines, which the FDA has not approved, that are just lying there. President Biden has announced that he will be, the US will be donating hundreds of millions of shots of the Pfizer vaccine, and under another umbrella, I think about 25 million to different parts of the world that are seeing a surge in cases. It only amounts to about 2-3 million doses for India. But is the US doing enough? Do you think that there is more that the most developed nations can do and should do? Because this pandemic is not going away until the entire world moves onto this sort of vaccination road, isn't it?
Yeah, I think this is a very good question. So just to be clear, the US previously were restricted from sharing its first batch of vaccines because they were signed under the Trump administration's Operation Warp Speed. And in the contracts, it says none of these vaccines may be shared or used outside of the United States territories. But the new batch of Biden vaccines do not have the restrictions. So previously, he's already committed about 80 million doses, but now, and also several $billions to COVAX. But just yesterday, they announced that Biden will be contributing 500 million doses of Pfizer vaccine on top of the 80 million. And I think that's just to start, because there will be a lot more as we ramp up other vaccine production, Johnson & Johnson, Moderna. The US will be ramping up purchases of this and donating this as well. The 500 million doses is just the initial first batch. And I think that's what, Biden administration is very different from the Trump administration, because they want to actually solve these world global issues. They want to actually show diplomacy and collaborate diplomatically with the rest of the world. So I think in the coming years, I think we will potentially see over 1 billion doses donated. I'm pretty certain for that. 500 million doses is just to start. That said, the TRIPS waiver, in which waiving the patents on WHO for these COVID vaccines, I think is key. But I think in addition to TRIPS waiver at WHO level, there needs to also be technology transfer, because there are factories from Bangladesh to Canada who also have the capability to produce it. They just need a final level detail of technical know-how. And that technical know-how sits in a lot of the pharmaceutical companies that currently produce them. So I think that tech transfer, not just the waiving a patent by itself, is needed to truly ramp up production. And that requires global cooperation as well.
I just want to come back to the question of variants for a moment. And I just ask you, is it correct to say that the Delta variant is currently the most worrisome variant that the world is looking at? Because one, again, there's so much information that comes in. I read last week that in Vietnam, there was some variant which was a cross between the one that had originated in Britain and the one that had originated in India.
That one is a Delta variant sublineage. It's WHO still says it's the Delta variant. Yeah, Delta variant, I would say, is the most worrisome. As I mentioned before, it's as a trifecta: more contagious, more severe, and has vaccine efficacy, vaccine neutralization issues and that's lower. Now, granted, there are variants that have worse neutralization potentially than Delta, like the South Africa variant. We know that AstraZeneca vaccine is just not that good against the South Africa variant. Luckily, the South Africa variant does not spread that fast, nor as severe, but it has huge reinfection potential. So I think there are different variants that could further emerge. Delta variant will not be the last worrisome variant. And although we fixate on Delta variant right now, we have to obviously see vaccines roll out as fast as we can, because there's a race here. First of all, a virus can't mutate if it can't replicate. So actually stopping transmission is actually the best way to stopping variants. And right now we have a window in which vaccines work against all these variants. I cannot guarantee in 2 years, if this keeps going, whether the variants that develop in 2 years our old Wuhan 1.0 design vaccines will still work for. And that's why we don't want to be on this vaccine treadmill where, the rest of the world is still trying to get its original vaccine. This developed world is already on boosters for new variants. And then it creates another second tier cycle. And it creates this, my vaccine is an old vaccine. It's an old outdated vaccine. We don't want to create that kind of situation. But the window will eventually close, and eventually new variants that escape vaccines enough will really proliferate. So this is why the Delta variant is just one example of we're approaching more and more of that frontier day by day. So that's why we have to vaccinate quickly, not just roll it out and make sure the world gets it in 2 years.
Ruchi Sharma, are you on the panel? Ruchi has a question. Ruchi?
Hello.
Hi, Ruchi. Go ahead with your question, and please tell us who the question is for.
I think anybody can take. No preference for that. So I have a loved ones in UK, and I see them when I think last weekend only I was looking at their pictures, and they had some dad-daughter camping something, and I saw no one was wearing a mask.
Wearing masks.
Like kids were playing with each other without no mask was there. So I'm really worried, like why the UK is not stressing on the need for mask at this time when the Delta variant is going over there.
For kids in particular. Yeah,
that's a very good question. Many scientists and other independent SAGE experts have been saying UK needs to mask its children in schools. I think that's one really, really worrisome thing. And UK needs to upgrade its ventilation and air quality indoors. But UK has done neither of that. US at least has doled out hundreds of millions of dollars to schools to upgrade their air quality systems. And the CDC recommends masks for kids over the age of 5. But UK does not have any of that. Now, granted, outdoors is less of a worry, but indoors is the main worry. And that's where we see so much transmission.
Yes, and as you pointed out, ventilation therefore becomes very key. Sujatha Rao, there's a question from Abdul for you, asking that will district level serosurveillance along with EPI cluster sampling methodology work in identifying districts to be vaccinated instead of just going all out with mass vaccination, a more targeted vaccination?
Absolutely, I believe that. Because we are not getting all the vaccines that we need at one time to inoculate everyone at the same time. You know, the way we do in our immunization programs for children, we are fully stocked to cover every child at the same moment. That's why the polio pulse was for 1 day. So here we are getting them in phases, so you have to prioritize. And that, I believe, will come only with more and more of evidence drawn from serosurveillance studies and other epidemiological data of, death analysis, mortality, morbidity, the nature, the whole characteristics of all that, to identify and profile the vulnerable population groups and areas where the hotspots, where the vaccination should be taken up on priority, rather than going off to some place where there is less of a priority. I think such prioritization is absolutely fundamental.
My question, and both of you could answer this, on the issue of travel. There's also controversy about this idea of having vaccine passports and whether countries should only allow vaccinated people to enter their borders. But I just want to know from a health perspective, if even vaccinated people can potentially be carriers of COVID and infect others, would we all still, or should we all still be required to do an RT-PCR test before we travel and when we get to another country? How do we deal with that? Dr. Feigl Ding, if you want to take that first.
Yeah, I think we should still have testing in addition to vaccines, because as we know, vaccines are good for hospitalizations, mostly good for symptomatic, but we know that asymptomatic, the efficacy is always a little bit lower, and that's oftentimes not capturable from regular studies. So, and we also know that testing is good. Testing is, especially, I think of testing like a rake. When you rake your leaves, it gets most of the cases. And if you rake again, you will get more and more, but it still has gaps. Cases can get through testing, as we've seen most infamously at a White House outbreak. They relied just on testing, but clearly it led to a big outbreak because they only relied on one fence of testing. So I think the best, obviously, is quarantine in addition, but quarantine is very onerous. And so I think we definitely need testing, vaccination if possible. And if you don't have that, you should do a quarantine without. I think you should do it definitely at least 2 out of 3, vaccination, testing, or quarantine. Doing 1 out of 3 is just not enough.
That's going to make travel very difficult, Sujatha Rao, isn't it? The idea of, I
think so, but at the same time, if you weigh the benefits and costs, it's better to be more cautious than be taking risk. But in India, we are at a different trajectory altogether. Even as such, we are not testing enough. After all, UK does about 40 tests per million, and we are doing something like 13. Of course, we're a little better than, 40 for one positive test in UK, and whereas we do 13 tests for a positive case, and we're a little better than Brazil, which does 4 for a positive case. So there's a huge gap between our ability to, our testing strategies and testing numbers and what we ought to be doing. So I think in India, it's very, very important that we not only vaccinate, but wear the mask without fail. And if for traveling, it's better to do the RT-PCR, particularly for those who are coming from outside for us. I think it's good to really take those precautions.
We're down to the last few questions, and Dr. Feigl Ding, to you first. There is a question here about whether there is any data that we have on adverse effects of vaccines on those who have comorbidities. Is there any data that has popped up on that?
Whether the vaccine has greater efficacy for those with comorbidities,
or whether it has any adverse effects on
adverse
greater.
effects. So I think it depends on the vaccine. Obviously, the AstraZeneca has the clotting issue, although it's still extremely rare. But we don't really know the exact risk factors that increase the risk of clotting. It's just a very rare clotting condition. We just don't know enough. There's some discussions of heart inflammation, myocarditis, and that's still under investigation. But I don't think that is an underlying major thing. I think we'll resolve this pretty soon. I think pregnancy is relatively safe. If anything, pregnancy, the vaccine will actually induce antibodies that the mother can transfer to the baby through the placenta, as well as through breast milk eventually as well. So that's actually protects the baby, even though the baby's not vaccinated. The mother being vaccinated, transferring the antibodies to protect the child is very favorable. So I think vaccinated mothers should definitely, pregnant mothers should definitely get vaccinated. As for high risk factors, I don't think there's high risk factors. There is, for example, autoimmune disorders. The worry is that vaccinations does not induce enough antibody response. And because it doesn't induce enough antibody response, people who are autoimmune may not be as fully protected as other people, even though they are vaccinated. So I think we have to be vigilant for those who are immunocompromised that it's not enough. And of course, diabetes is an exacerbating factor, especially with the black fungus phenomenon that we're still trying to study. Diabetes, some people think, really is a major contributor to the black fungus among COVID infected. So I think if anything, people with diabetes should definitely get vaccinated. But immunocompromised people, morbidities, definitely have to be more careful than everyone else. But more likely, they should definitely get vaccinated.
Sujatha Rao, question here from Wasim. To what extent have we fudged data with respect to both infections and deaths due to COVID? Will we ever get to know the real data? And let's face it, that's a legitimate question.
Fudged is such a strong word. So, I'd be hesitant to use that word because I also worked in that system for so long. So it's a harsh indictment on my own my colleagues now. But, I won't say it's fudge, but definitely there has been suppression of data. Let's put it more decently. Okay. So in several states, and that's largely because, as you observed earlier, that it has been so badly politicized and the politics in India is so polarized. So, when at the prime minister level or at a senior review level, the perception of media particularly contributing to it, as if large number of infections is a failure of the government, rather than a better recording and a better testing rate. And low infections shows, oh gosh, that's a model that has to be replicated, even though it may be just suppressed data. This kind of competitive politics have certainly marred and marred the entire data collection. So much so that the Prime Minister had, if you remember 2-3 weeks ago, came out and said that please be honest with your data, don't hide it, and that's not a reflection on your capacity or capability, please tell the truth. Now, and so far as death is concerned, you saw the Bihar data today where I strongly believe that we can safely say that if we are recording 3,000 deaths a day, there must be not less than 6,000 to 7,000. Definitely by 100%, there has been reduced recording of deaths. Now, this could be for one or two reasons. One is, actual not reporting systems are not very well tuned in, particularly in rural areas. And but the second is also misclassification that that got Tamil Nadu, for example, and even in Maharashtra to revise the death rates. Because when you are a person with, say, a heart problem and you die of COVID, which block do you put him in? Do you put him in the cardiac heart failure thing, or do you put him in a COVID box? So this kind of a thing also, misclassification did take place, and some states are revising it, and so there'll be an upward division. And the third was, particularly initial years, the stigma that followed. I know in my own family, not directly, pretty distant relatives, in 2-3 cases, they hid the COVID information, because those days, if you remember the first wave, if you were a COVID patient, then you couldn't do the rituals, you couldn't access the body, and the body would be dumped somewhere else. So for all those kind of cultural and social reasons, they hid that data, and so it was never registered as COVID. So for all these multiple factors, there has been a suppression of COVID deaths. There need to be a very serious openness, and seriously, we must review and update our data, both of infections and deaths, because it's not going to be helpful for us to understand the full impact of the COVID on our strategies and policies. And our policies can never be useful if they are based on wrong premises. So I think it's very important that we have good quality data.
On that note, I have a last question for both of you. Both of you can answer this. It's from Kundan Kumar. That what are the lessons that we have learned, or we should have learned, in identifying when the next wave is approaching? Because when the second wave came, as he puts it, it was like a tsunami. How did we miss the signs? How do we identify the signs of a future wave? Is there a definitive criteria? So I'll take that to both of you. Dr. Feigl Ding, to you first, and then Sujatha Rao with the closing comments. Yes.
I think the first thing is that there's two problems. One is politicians are always late to act because they don't want to act until things are really, really bad. I think the lack of precautionary principle is oftentimes play here, and hesitation of should we act, the inclination to sit on your hands rather than take action. It's easier to take no action than to take action. And for scientists, oftentimes, they're oftentimes too late to vocalize because they're worried about shouting too early, because that's not how scientists are supposed to behave. And again, I think the precautionary principle should win out, that we should be careful. And sometimes, what is exponential increase or late? People think of when the line starts going like this, that's exponential. No, exponential increase is the same thing when it starts very slow. And I think this failure to act on early signals, we eventually pay a steeper price, because we don't want lockdowns. Nobody wants lockdowns. Economically, socially, it's bad for everyone. And public health scientists don't want it. But had we taken action early, we could prevent it. But I think oftentimes, politicians also want to win political points, and showing weakness in taking these mitigation measures, they feel like they're losing. But in the long term, an ounce of prevention is worth a pound of cure, a pound of hospitalizations and deaths. And so I think this is where I think we should always lean to the precautionary principle and really lean on the side of, we may not be certain, but we should take the more precautious road, especially when it comes to global pandemic.
Sujatha Rao, your thoughts?
Well, I believe that we have a lot of data, accumulated knowledge sitting there with us, very contrary to what the situation was last year. Yeah. But even so, when you hear Dr. Eric, you could have made out how many unknowns still fog us. So the unknowns to unknowns to unknowns still, despite all the mountains of data that we have. But the tragedy with India is that even those even the mountains of data that we have is not made public. And INSACOG, which is a laboratory-based network of biostatisticians and epidemiologists, gave a public statement requesting the government to make the data available to them, because every bit of data needs to be very closely scrutinized and studied. And for example, genome sequencing. They say that it should be at least 5% as a goal mark. We've done hardly one. Maybe we have, with all the criticism, might have gone up to 2% of that. With the result that we are not going to be able to see whether the vaccine is mutating. If it is mutating, to what extent it is mutating, to what characteristics is it mutating, and to take advance notice. Had we been doing this genome sequencing, we may have identified Delta when it occurred first in Maharashtra and taken some action against that. They haven't done that. Now we are going to buy Pfizer, but Pfizer's clinical trials were all done in the US. So we don't know how sensitive it is going to be to Delta, which is the main variant here.
Apparently not as good as.
Okay, so Pfizer may be a flop.
As per data that was published abroad.
Oh, it's a foreign vaccine we've got. $20 a dose you're paying, so you must be extra protected. But actually, it may be a most irrelevant vaccine insofar as the Indian context is concerned. So all this and more comes out only when we analyze data, because there's so many unknowns. Even with the vaccine, we don't know how long immunity it will give. Most people in the US believe that Moderna and Pfizer gives immunity only for about 6 months. I mean, you know,
about the boosters. Yeah.
Yes. So we don't know anything at all about COVAX and Covishield. Even that little knowledge we don't have. So there's several other aspects which are so critical for our getting back to a normal life, that I think it's very, very important that we do our data analysis and try based on evidence, try and project what could be happening and when it could be hitting, rather than make anecdotal basis. Finally, another root requirement is surveillance. Constant zero surveillance at district level and below, constantly looking at, is there anything unusual happening, and be sensitive to those messages. We are not listening. That's our problem. When a case comes up, we just say, oh, it's okay, that may be one case. But we must learn to listen to data, because they always invariably signals come before the tsunami occurs. And we have to learn to listen to those signals and take precautionary action. Well, lastly, I would like to say, Nidhi, no matter how well prepared we might have been, but wave 2 was really a huge, a fourfold or a sixfold strike. And we could never, our health system could never have been able to cope, even had we been careful. So, nature is that, the risks are there, but all we can do is to minimize the risk and the pain. That's all that we can do.
Well, that's very good advice from both of you. Dr. Feigl Ding, they're talking about the need to keep your guard up. You are talking about using data and arming ourselves with the knowledge from that data to anticipate what may happen in a future wave. I would like to thank both of you for joining us on this session today. It's been really valuable to get your insights on, both on policy, on health, and it looks like, unfortunately, this pandemic is here to stay at the moment. So we all need to find a way to navigate around that and deal with it the best way we can. Thank you very much. And I hope that you both stay safe.